said Monday. I don't know why. Happy Friday, everyone. Thank you for joining us. My Ravi was the last person to speak in the pre VMR hangout, and for some reason his picture remains blown up and massive on my screen, and I couldn't think of no better way. I don't care about the whiteboard today. I don't even need to see Prof Rez when he pops in. He's going to be a little late. In fact, quote, he said, "Will be a little tard, but not plutard," which, if any of you speak French, you'll recognize that is what Ravi coined. What did you say, Ravi?
Franglish.
Franglish. Yes, Franglish. We speak Franglish on this podcast now. Anyway, Reza will be joining us momentarily. We're so excited to hang out with you all. And as always, we'll lean on one of you to present a case. So please, please, please let us know in the chat if you have a case you want to nerd out about. In the meantime, we have many wonderful CP Solvers team members, one of whom just moved across the country. Madalena, tell us what you've been up to.
Hello, everyone. I'm Madalena, and yes, I just moved across the country. I just finished my 3rd year in New York, and I'm taking a year off between my 3rd and 4th year, so I just moved to San Francisco. So it is absolutely beautiful here, and I'm really, really excited to be here. And I did just want to stay, I think for me, this morning has been very, challenging to focus. I think, as probably most people have heard, the Roe versus Wade ruling came out. And so I just want to acknowledge just for me personally, I feel devastated and outraged about what this decision means for how it will, worsen these already existing disparities. So I just wanted to make sure that was just voiced and let everyone know that no one's alone in feeling this kind of outrage and devastation here. So just wanted to acknowledge that a little bit before we dive into a case.
Hi, Madalena. I've been doing a phenomenal job of avoiding the news for a lot of reasons, and so I didn't know that till this moment. And so thank you for saying it out loud. And I think many people in the chat are acknowledging it. And I think Andrew said it best. It's really a deadly decision. That is not just an opinion. That is there's a tremendous amount of evidence for that statement. So thank you, Madalena, for voicing that. Thank you, the chat, for also acknowledging how you feel about this. And Andrew, I completely agree. It really is a deadly decision that is incredibly unfortunate. And it's amazing to me how many times we've had to have conversations like these or acknowledge conversations like these, not to equate things and to put things in buckets, but decisions, events, experiences that just kind of put you in that very similar rut of what is wrong with the world. And you could sit there and be like, how many times do we have to do this? And acknowledging that here before you is somebody who is a man and cannot get pregnant. I'm not the best person to share this reflection with you, but I will tell you that it's still incredible that it's both devastating that we have these many conversations, but it is incredible and inspiring that we're still here showing up to have these conversations and to feel this outrage and to feel this anger and to feel motivated to try to do what we can, however we can, to remedy what we feel is terribly wrong with the world. So I'm sure there'll be tremendous consequences to this. I'm sure none of you will be silent about it, however you choose to speak, either to yourself, to others, loudly, quietly. But yeah, I'd love to mute and see if there are other wonderful people in this community who have thoughts to share, because I think we should create that space for a little bit today. And it's okay if nobody says anything. I'm prepared for that awkwardness.
I cannot not say anything, right? Madalena, thank you so much for bringing this up. And yeah, it's been absolutely devastating. I feel like I've known this for a month. I expected the decision to come out today, and it was a completely gut punch. And as you mentioned, Robbie, I'm just so incredibly grateful to have friends and communities who feel my outrage. And, I think it's easy to also give up and to say, like, oh, everything is bad and not to do anything. But people's life will really depend on it. So, I think it's, especially as physicians, we have an obligation to advocate for our patients and for those who can get pregnant and might not have as a strong of a voice and a platform. So this is just the beginning. I'm going to go for sustained rage. And I can't think of a more important issue to advocate for and to vote on and to figure out a way forward. Progress is never a straight line. It's a lot of back and forth, and just gonna keep at it. I refuse to believe this is going to be the status quo. I just refuse it. So I think progress, a lot of back and forth, and we just have to keep moving forward, and we have to find little things to latch onto, and the sense of community, and the sense that there are a lot of people who do believe in women's right to choose and equality. And I'm gonna put my faith there and see where it takes us.
Thank you, Charmaine. Yeah, sometimes reflections take up more space than the need, and I would just let that stand. I think that's very well said. I can't think of anything better than Prof. just dropping in this space, having no idea what's going on. So to transition from that, not to really transition from that, but to move in parallel with that. Does anybody have a case that they would like to present today to get us going on VMR style as we power through and will always power through? Prof. Rez is here. Hello. Prof. Rez.
Bonjour, bonjour mon ami.
Bonjour.
Comment allez-vous?
Je veux bien. Madalena just shared with us, I'm not sure if I didn't actually know any of this news, but Madalena just shared with us the unfortunate and devastating news that Roe v. Wade was overturned today. The official news was leaked. And yeah, I think we just heard a lot of reflections from the chat, which I know you probably can't see, and also heard from Madalena and Charmaine and many others. So this took some time to acknowledge that, and we'll continue to acknowledge it. And
yeah, to me,
didn't want you to like not know what we'd do.
Right. Coming with all this happiness and speaking French and like butchering the language. To me, what this represents is that the Supreme Court is no longer bipartisan, and it's sort of a regression, in the United States. And what I fear most is that this is just the start. This is just the start of a very right-wing, Republican centered Supreme Court. It is what it is. And unfortunately, I hope we can change that, because people's lives are going to be negatively impacted. And it's not just women. Next, they're going to go after equal sex marriage. And it's just going to be going backward and backward. So it's a terrible day in our country, but hopefully it's just a small regression, and that we find our way again. And we need more equality on that Supreme Court. It's too one-sided right now. But does anyone have a case for today? can I smile now?
Yeah, you can smile, man. Yeah. So thank you for acknowledging that. I think people really appreciate how direct you are and how you don't dance around anything and going after the root of all this. Is there are many roots. Yeah.
I actually like texted like my sister, my
Yeah.
part, and because it's just so sad. It's like horrific. It's horrific that this is what's happening. And we'll see if Biden can do anything with his executive power, but hopefully it would be done through the right and proper channels of the Supreme Court. But
Yeah. I like the toothbrush you have, by the way. Is that a new toothbrush? What is that? Right by your printer?
yeah, I'm getting Invisalign on my, and so I need a toothbrush close and handy. Yeah, exactly, Charmaine. That's what I'm most afraid of. So James, you have an NEJM case. Is it from this year or?
Yeah, let me see. Because I download like a bunch of them when I had to go on like a plane flight from Florida to Michigan. So I kind of want something to do. Let me see what year.
Because Robbie knows those cases better than I know the direction from my house to the hospital. By the way, James, it's so nice seeing you. I know we've been corresponding via email.
Yeah, no, it's good to be here and be helping. Yeah, this one's from 2022, so I don't think I'd trip you up at all. But yeah, that was the only one that I had. So
let me ask you this question. Are you pretty much off today?
Yeah, I'm off pretty much the 28th, and then I don't know the next time I'll be off, after I start.
I will connect with you today so we can do the PETH video, and then maybe we can have Alex because it seems like he saw a case yesterday, because that case probably both Robbie and I have done. But maybe we can have Alex present a case, and I'll connect with you later today, James. And I'm sure during your intern year, you're going to have so many cases to bring to us, and we will happily discuss them. And nice apartment. It looks good. Alex, please unmute yourself.
It's very rough and impromptu, but happy to jump in and present.
Always a pleasure, my friend. I get a little nervous when you present, Alex. We don't know where this case is going. Robbie, do you mind tackling the first aliquot?
You got it. It's great to see you not indoors, Alex. Not as great, but usually Alex comes in, shows up on VMR, chilling outside, making me feel real jealous. So I'm glad we're in the same boat today, Alex.
I actually am outside.
You are? Oh my gosh. Thank you for slowly delivering that news to me. I appreciate it. All right, we're ready whenever you are.
All right. So I have a 58-year-old lady who presented with shortness of breath and cough of 4 days duration. So basically the story was that she had what she thinks was a viral upper respiratory infection a couple of days ago. And then felt like her condition was getting better, but then all of a sudden her shortness of breath got worse. She had a more productive cough and presented to the hospital. I then met her on the medicine floor a couple of days after she had been admitted to the hospital. She had been on antibiotics for 3 days, feeling much better, but still having a consistent oxygen requirement of about 3 liters by nasal cannula and saturating at 92, 93% sitting in bed. So I guess that's where I'll leave us.
Yeah, Alex, this is a phenomenal start, and I think that how well you're presenting this case, or how well this case is a function of how rich your understanding is of medicine, which is clearly very advanced. And when you're in this space, the question is, where do you begin? What do you begin your analysis with? And I think that you really, really can start to deconstruct the story from its origins, or you can start to deconstruct its story from when you originated within it. And that, in simple terms, means you can start from the beginning for the patient or the beginning for you. And I think the beginning for you is probably more firm ground, because everything that has happened in the distant past is a little bit less closer to the truth, meaning none of us were there when she had this viral URI and what those symptoms were. None of us really evaluated her shortness of breath initially. What you can see right before you is the presence of hypoxemia. And so I would start there. I would say, like, what is my approach to hypoxemia, and what does the context of the preceding few days and then weeks help analyze that? And the presence of hypoxemia in most patients implies a dysfunction at the interface of the alveolus and the blood vessel that exchanges oxygen. And the presence of a cough, a viral URI symptoms tells you with a high degree of certainty that you have a problem in the alveolus. And that alveolar problem can be that the alveolus is full of pus or fluid, or it can be that the alveolus is collapsed because there's mucus plugging, or that the alveolus is collapsed because there's external pressure on it from a pneumothorax or a pleural effusion. And so I think the key move in this patient is to ask yourself, what does the X-ray and what does your stethoscope tell you? Because both those things can reinforce the notion of an alveolar process. And if they're persistently negative, you might have to think about a vascular process. And that would be the simple analysis that I would make, recognizing that there are a lot of clues to try to pick up on in the background. Her shortness of breath, her cough of 4 weeks duration, which is very intriguing. But that's where I'd start. Like, what does my stethoscope tell me? And what does the X-ray tell me? And then I would use, after making progress in that space, use the peripheral clues to make further progress. Prof. Rez, what struck you with this case? And I don't know if you have thoughts about the peripheral clues already, or you want to save those for later, or not at all. Or here's one more option.
No, I have a zero to add. Now, I love the word interface.
You know it in French?
I can barely say, where is the toilet? Où est la toilette?
That's pretty good. That's pretty good. All right, I'll explain it to you.
All right. So I guess just to add a little bit to her hospital course, trying to remember some of the details. So I think that she had been on levofloxacin for 3 days. And I think I might have mentioned this already, but her cough and her dyspnea really had resolved the problem that she was presenting with to us at this point. Really was the persistent asymptomatic hypoxemia. In terms of past medical history, she really had minimal to none. I think she may have had hypertension. That was about it. Meds, if she was on an antihypertensive, I don't remember it. And then obviously the levofloxacin. Today was day 4 of anticipated a 5-day antibiotic course. Family history, she had diabetes in a parent. Social history, she lived at home alone, and I think she worked as an accountant. No known smoking history, no alcohol use, no drug use, and no known allergies. Then in terms of vitals yesterday morning, so she was afebrile, temperature was 37, heart rate was 95 at rest, and then when she got up and walked, she got up to about 120, 130. Blood pressure was 110/70, and her respiratory rate was 16, and oxygen saturation we already mentioned, like 92 to 93 at rest, and then with minimal, and at rest on 2 to 3 liters nasal cannula, and with exertion still on 2 to 3 liters nasal cannula, she would dip down to about 88, 89%. In general, she looked very comfortable. She wasn't using any accessory muscles of respiration. She wasn't tachypnic. I guess notably another vital sign that maybe I would mention is that her BMI was about 40. No conjunctival icterus, she did normal S1, S2, no murmurs that I could appreciate. She had slightly decreased lung sounds at the bilateral bases, but no rales, no rhonchi, no wheezing. Abdomen was not tender, and her extremities were warm and well perfused, and she was not diaphoretic. And then grossly intact neurologic exam. So I think I'll stop there.
This is a phenomenal case for so many reasons. One of the important points that you should walk away with is shortness of breath is subjective. You can't tell anyone that they don't have shortness of breath. You can't. That also applies to patients with vaso-occlusive crisis and sickle cell disease. You can't tell them they're not in crisis. But you can tell someone they're not hypoxemic. So there's a disconnect here. There's no dyspnea, but there's hypoxemia. So that's going to be fascinating to analyze when we get to the end of this case and get a diagnosis. The other thing that's super interesting, Robbie, is the fact that we have a preceding course before the onset of hypoxemia. So the question becomes, not question, quite frankly, when you frame this patient, you have to use the sequence of events and give it weight. You're open to the fact that it may be true and unrelated, but it would be wrong not to prioritize whatever occurred in that hospital or with that illness is related to what's happening right now. You have to approach it with that frame. But before you apply the preceding course to the clinical syndrome, which you're trying to solve, which is hypoxemia, it's good to just share a generalized approach to hypoxemia. I shared a video in the chat. I'm going to share my screen for a second. Actually, I'm not sure why I can't share. Robbie, can you make me a co-host, please? Oh, perfect. This is all I need. Don't make me a co-host. Okay.
You're muted. You're muted.
I said, let's play this for the next 8 minutes, but I'm just joking. So here, no, pause it. I just want to show the schema that's on the board. And basically, thank you. So whoever's navigating the screen, thank you for blowing it up. This is like incredible. So you have to get oxygen. So is there an issue with oxygen acquisition? We know that this patient's BMI is high. We know that this patient has probably OSA, if Alex didn't mention it to us. They're at risk of obesity hypoventilation syndrome, but I don't think it's the case. It could be that this patient is just more vulnerable to hypoxemia, tipping them over because of their body habitus, but I don't think there's an issue with acquisition. There, the clue is that CO2 will be quite elevated. Then you go down here and you're like, okay, the oxygen gets, where Robbie said there's a alveolar vessel interface. And here you can think about the airway, the parenchyma, and the alveoli. So you see, Alex told us that there's decreased breath sounds at the basis. So you have to entertain the idea of pleural effusion. But the pleural effusion shouldn't cause hypoxemia unless it's through atelectasis, because pleural effusion causes dyspnea through its impact on the diaphragm and allowing the diaphragm to create that negative intrathoracic pressure to allow air to come in. So it's going to be interesting when we get this X-ray. Is there a pleural parenchymal disease process or not? And then, of course, the vessel. Robbie said, listen to the lungs. I can't, attribute the hypoxemia to the decreased breath sounds at the basis. And remember, the habitus being, increased, it's harder to auscultate. It's harder to auscultate. So we have to be open to the idea of like a vessel issue too. So I do want to pass the mic to Robbie to sort of layer in on the current presentation course, but like reflexively, I want a CT scan of the chest. I want it with contrast, which will give us info into the parenchyma, the pleura, the vasculature. And initially, when you were telling me the story, Alex, especially if the hypoxemia was constant, I thought about methemoglobinemia and thinking like what exposure she might have had. These patients oftentimes have sort of distal cyanosis. They don't feel short of breath, but their oxygen saturation goes to about 85. And when you do an ABG, they have this chocolate auger, but this is a little different in that it actually worsens. So let me pass the mic to Robbie, but that's sort of the general framework. Then we use a sequence of events and see if we can make more progress. But this patient needs a CT with contrast.
I think that's absolutely superb. And by the way, when you blow up that video, I only look at you. I forget to look at the schema. But I think, the dimension of this case to analyze, and I can't make it actually a productive analysis for you, is when people are hypoxemic, you're usually meeting them as they get sicker and sicker and sicker and sicker. And we call that like the concern for progressive or worsening hypoxemia. What strikes me about this case is the time course. This is very much lingering hypoxemia, which is honestly a pain in the butt for people who take care of patients in the hospital, because you can't quite figure out how far and how much you need to push this. It's not uncommon that a patient with this tempo of hypoxemia kind of lingers low grade, that you discharge them on home oxygen and you wait for things to resettle. So the real question for us to analyze, in addition to trying to localize the schema, is to use the time course and say, how is a differential diagnosis influenced by somebody who's having low-grade middling hypoxemia to the point where the provider is willing to actually exert them and walk them and see what their oxygen saturation is when they walk? Most people who are hypoxemic from a pneumonia ARDS, you want them to stay sitting in the bed. And the other clue here is, what do you do with the fact that there is worsening sinus tachycardia when you walk the patient? So I would say that I think that opening up this space gets murky and tricky, but make note of the fact that this patient is hypoxemic, yet the astute clinician taking care of her is inclined to walk her. What does that interface mean? And I'm curious to explore that further as we get more data. All right, Alex, back to you.
Interface is the word of the day, folks.
All right. So white blood cell count yesterday was 6.5, and that had been slowly decreasing over our hospitalization. I think it was about 15 when she came in with a neutrophil predominance. Hemoglobin was 11, and platelets were 150. Her sodium was 138, potassium was 4, chloride was I think it was probably about 90 with a bicarb of about 30. BUN was 18 and creatinine of 0.3, like 0.6. Glucose was 140. Calcium of 8.9. Mag and phos were 1.8 and 3.3 respectively. AST and ALT were normal, maybe in the 30s for both, and alphos, let's say, was about 85. T-Billy 0.2, albumin of 3.5. We got an ABG yesterday morning, which showed a pH of 7.43, a PCO2 of, I think it was about 55, and a PO2 of about 70, and that was still on the roughly 2 liters of oxygen per minute by nasal cannula. You guys want to stop there? Or do you guys want more data?
No, I think this is a great time to reflect on, and I'll take on the ABG and see if Prof. Rez makes anything of the remainder of the labs, which is that if you look at this PCO2, you see that it's elevated, but the pH isn't low. So it tells you that this patient has a chronic respiratory acidosis with appropriate metabolic compensation, which reinforces the notion that there's some form of hypoventilation. And the question is that hypoventilation because of impaired movement of air into the chest or an obstructive problem? And the absence of wheezing makes it very compelling that it's an impaired movement into the chest. Impaired movement into the chest is no different than cardiac contraction. There's two things that are required. First, the electrical impulse, and then the contraction. So pushing air into the chest requires the respiratory rate, which is the equivalent of the heart rate, and then also requires diaphragmatic force, which is equivalent to left ventricular force. Same process. For you to beat your heart, you need a heart rate and power. For you to pull air into your chest, you need a respiratory rate and diaphragmatic power. The respiratory rate is normal here. So the question is there an issue with diaphragmatic power? And in patients who are overweight, the most common cause is obesity hypoventilation syndrome. So the question is, does the obesity hypoventilation syndrome explain everything here? And the answer is maybe. The PO2 here, the PaO2 may be low because of the high PCO2, but if you calculate the AA gradient, it's actually abnormal, which means that the PCO2 is not the sole reason that the PO2 is abnormal. There is much lower oxygen than you would expect if it just was being crowded out by CO2. And so what causes hypoxemia in patients with obesity hypoventilation syndrome? There's one very common cause, which is that they have atelectasis. And the atelectasis causes VQ mismatch, which causes hypoxemia, but the more morbid causes are pulmonary vascular causes, either acute pulmonary embolism or chronic pulmonary hypertension. And when you're looking for that possibility, you can look over to see the hemoglobin to see if it's hemoconcentrated and elevated to support that notion, which it's not. So I think the ABG just tells you that this person almost certainly has obesity hypoventilation syndrome because they have hypoventilation with a normal respiratory rate and no evidence of obstruction. So the hypoxemia here is intriguing. It might be true and unrelated, but if it were related, it might be atelectasis and it might be pulmonary artery disease. Thoughts on that, Prof. Rez, or anything else you want to add?
I love that. I think the challenge, this is going to be really important in analyzing this case. You have to know exactly what happened at that other hospital and what was the patient's respiratory status on discharge. It's crucial. I can't tell you how many patients I've admitted with multifocal pneumonias that I discharged with oxygen therapy because I expected them to improve. And it highlights the importance of the walk test before discharging anyone with cardiopulmonary disease. That is, have them walk around with a pulse ox, check their heart rate, check their oxygen saturation. Because for us to get concerned, we have to know that this isn't what the expected course is for this patient. So for example, if Alex tells us at the other hospital, she was satting 88% with 6 liters upon ambulation, that would be an improvement, right? Obviously, it's not the case here that the patient ended up in the hospital and all these labs being done, but you have to do your diligence because like that patient with dementia who's at risk of altered mental status, that patient with chronic kidney disease at risk of AKI, that patient who has obesity hypoventilation syndrome has a vulnerable lung. Their lung isn't as healthy. And that's why Robbie said this could all be explained by an insult and the lung just needs time to recover. So I think that there's been a delta, but you have to analyze what happened at that hospital. What was the oxygen saturation? If there is a delta, this patient needs a CT scan of the chest with contrast to evaluate the vessels, to evaluate the parenchyma, to evaluate the pleural space. And the CBC got my attention, not enough for me to use it as the center of gravity, but it's borderline thrombocytopenic. We know there's anemia. The patient was inflamed, but I'm starting to keep it in the back of my mind. Is there some form of inflammatory or multi-systemic disease that may have a footprint on the bone marrow? I'm not there yet, but I'm really interested in hearing what the CT scan showed, Alex. And can you maybe inform us as to what the oxygen sat was at the other facility when she was discharged?
Sure. So just to clarify, she actually had been at our hospital the whole time. I was new to the team, so I was covering for a colleague yesterday. But the oxygen saturation had basically been about exactly where it was yesterday for the duration of her 4-day hospitalization. So I guess that's why I didn't jump immediately yesterday to get a repeat CT scan. She had gotten one on admission, and it showed no. I guess we're jumping into a little bit more data, but it showed no focal consolidations, really no pulmonary parenchyma. It showed evidence of multifocal consolidations, I should say, but no evidence of apart from that, a pre-existing pulmonary parenchymal disease. And it showed no clot in the pulmonary arteries, and it showed non-dilated pulmonary vascular, a non-dilated pulmonary trunk. We did get a repeat EKG yesterday, which showed just sinus tachycardia without any evidence of ischemic changes. And I guess I'll stop there.
Oh, thank you, Alex. So sorry. I was a bit distracted at the beginning of the case. So sorry for assuming the patient was at another hospital. Thank you for clarifying.
Not your fault at all. I think I didn't give enough detail. I'm sorry about
No,
that.
no, you were spot on. Hey, Robbie, I wanted to talk to you. So let's say you and I are on the medicine team taking care of this patient. The patient had a clear multifocal pneumonia and has a vulnerable habitus. Is there any reason for us to question, the rate of recovery? Like, if this patient was on your service, I'm just trying to imagine, like, what is the expected course? I think that's an important, question for us to think about, especially in a patient who is vulnerable. You know how we talk about immune compromised, immune competent? We should talk about normal lungs or potentially unhealthy, respiratory apparatus. I don't know the right answer. I was just curious what your thoughts were.
I think that's the hard part. I really struggle in this space because I think you could totally say, hey, I'm just going to send this patient on with some home oxygen. And I think it's totally okay to have a slow, gradual recovery. And maybe the patient didn't have positive airway pressure, so BiPAP or CPAP for her OHS, and that will be helpful. And I think that's the most kind of like the most hands-off approach. I think the most aggressive approach is to say, hold on, you have hypoxemia unexplained by intrapulmonary pathology. Could this patient have an intracardiac shunt as the most extreme hypothesis? And it's not a bad idea to say this patient has hypoxemia, gets hypoxemic vasoconstriction, gets acute pulmonary hypertension from that, and opens a PFO. And that PFO opening causes right to left shunting, and the patient has low-grade hypoxemia. And the only thing that will correct that is correcting the hypoxemic vasoconstriction that started in the first place. And we see this cycle occasionally in some people because 25% of us have a PFO, but most of the time it's closed. And whenever you have elevated right-sided filling pressures, it'll open again. So I don't know. I don't know what I'd do. It'd probably be depending on a lot of like nonverbal cues from the patient. How was her respiratory rate when she watched? What are her preferences? Does she want to go home? Is she worried about this? But I think the possibilities are home oxygen and watch and initiate positive pressure, or say, wait, hold on, could she have a PFO and get an echo with bubble? Apart from PFTs and diaphragm strength testing, there's not much else left in the world of dyspnea once you've gotten a CT with contrast. So how aggressive you want to be, I don't know. I don't have a good answer. What do you think you would do?
I think this is like why we're in a team. I actually recall a case when I was at Hopkins similar to this, except the patient had a PE and that caused acute pulmonary hypertension. It did open up the PFO and then caused right to left-sided shunting. So in someone like this patient who's at risk of pulmonary hypertension, could the acute insult have so based on that conversation, I would proceed with an echo with bubble to see if there is, the delayed bubbles. That's like the last test I imagine we can do. And again, I guess I'm just struggling because I think it's difficult to discuss a case like this too if you're not like with the patient each day, because we are fishing for something, because we are at a report style. But if you're with the patient each day and you're like, why is that troponin always 100? It shouldn't be always the high sensitivity troponin. Let's further evaluate this. So I agree, like if there's some question, but I think that's a fantastic thought of a PFO opening and would probably be the last step, and as opposed to repeating a CT scan and seeing if there's now a thrombus post, viral hypercoagulable state.
All right. Awesome discussion. Thanks so much, guys, and everybody in the chat. We hadn't thought about the possibility of opening up like an intracardiac shunt or an intrapulmonary shunt. So I genuinely hadn't thought about repeating an echo or performing an echo yesterday. Basically, what we did was we thought that, kind of like everybody had said so far, we thought that she had evidence of hypoxemia that probably was explained by more than just the obesity hyperventilation syndrome that had not yet been diagnosed. So our goal throughout the day yesterday had really been to ambulate her as much as possible and try to give her chest PT and spirometry to try to open up her any atelectatic lung that she may have had from being basically confined to her bed for the previous week or 5 days or so while she had been in the hospital, and maybe preceding 5 days or so while she had been sick at home. Her hypoxia yesterday did improve slightly by the time I left last night. She was maybe up to about like 95, 96% on like 1 liter nasal cannula at rest, but still desatting when she walked a little bit with me. So basically my plan leaving the team back to my colleagues for last night and into today was to see if they could do like kind of the same thing into today. And then if they couldn't, probably to talk to a consulting team to see if, I guess practically heading into the weekend, we thought that it would probably be hard to get her oxygen before Monday, and she was anxious to go. So hoping that we could manage her hypoxia in the hospital and get her back home in a safe way. And if not, to involve some consulting teams, and then I guess to consider an echo study, which we hadn't thought of yet, or a repeat CT scan or potential nocturnal positive airway pressure for management of a likely diagnosis of OHS.
Wow. First of all, thank you for commenting on intracardiac versus extracardiac shunts. I misspoke. With the intracardiac, it's early bubble. With extracardiac, it's later bubbles. Alex, this is such a beautiful case for VMR. Like, why is this such a beautiful case? Because this is 99% of what you'll see. 99, not to say that the other 1% isn't important, because they represent human lives, but you're going to see much more of this. So you have to be much more comfortable with this. And I think for me, the highlight is, like, if someone is vulnerable, their road to recovery is delayed. And you look for any reversible causes. So this idea of like opening up atelectatic lungs while the lung is healing and treating OSA, I think it's a great fit, Alex. And if the patient felt comfortable, I would feel totally comfortable not doing any further studies, sending them home with follow-up. But I just want to end on, this is the case you need to be very comfortable with. And the uncertainty in medicine, but understanding vulnerability in a host, and what's the expected course. And so I really love this discussion. Robbie John?
I couldn't agree more. I really, really hope that we continue to create the environment where the more common scenarios are ones that we get to talk about and discuss in VMR, because I think we get our CPS muscles are hypertrophied, and I think it's easier for a lot of people to diagnose miliary tuberculosis than to pick up a case of, I don't know why this patient has hypoxemia. They're so much more complicated and hard to tease out. And I think that, what you're seeing here is essentially like the delirium of the lungs, where patients with chronic lung conditions take a longer time to heal and the longer time to wake up and get back online. And I think that really, like, if you ask yourself, what really causes that lingering low-grade hypoxemia that takes a long time to clear? It's not many diseases that cause devastating hypoxemia get worse and worse and worse without treatment. So I think I would love to practice this with you all and to get more cases like this, because I don't feel very comfortable in it. But I don't think I've had a patient who's had like low-grade middling hypoxemia that persisted who had a bad outcome. Almost always just it takes a little bit longer time for them to recover. And I think I learned about chest PT. I don't think I've ever prescribed that or done that. And I'm curious if any of you know about it in the chat, or Alex, if you can expand on what that meant for you. Like, was that like, was it like a cappella and incentive spirometry, or was it like, what did that entail?
Yeah, so I guess it's kind of maybe a bit of like our hospital's jargon, but when we say chest PT at the hospital, I think we mean more what you're referring to, Robbie, the a cappella devices, and the nurse is kind of giving her, like, I guess physically, what's the right word, but like hitting her back to try to mobilize any secretions. And in addition to using incentive spirometry, I think maybe a little bit different from what Robbie was referring to, where she like goes to like a special physical therapist who can help her with recover from her pulmonary disease.
Yeah, they actually have some of the beds in the hospitals have features where they shake, but they even have, I remember one kid had some actually fractures to the ribs, which they for some reason tried this belt thing that essentially like shakes your abs, and he wasn't enjoying it, but that was like kind of my attending thing, like chest physiotherapy for everyone, surgical IV. But yeah, it looks like one of those old ab machine things that shakes you.
Awesome, James. Thank you for sharing that. And thank you, Alex, for a really, really cool case. I think being able to present somebody who you met briefly for one day and to tell the story the way you did was awesome. And I really, really enjoyed talking about, I don't think we've ever talked about this on VMR. We talk about hypoxemia a lot, but this is really, really neat. So thank you. All right, Madalena, take us home, please.
Okay, awesome. Well, Alex, just really, I want to echo what Robbie and Reza were saying. This really was an awesome case and something that I'm still trying to develop my approach to. So this is really, really helpful. So we started off the case by talking about an approach to hypoxemia. And Robbie kind of distilled this down as hypoxemia implying a dysfunction at the interface of the alveolus and the blood vessel. And then Reza sent us this awesome link to a video that I'll have to watch, which kind of really lays out the approach to hypoxemia. So you can start with, is this an issue with O2 acquisition? And then you can move on to, is this a pathology in the parenchyma, the pleura, the vasculature? And when we got a little bit more information about the HPI and we learned that the patient had a cough, when you see a cough in the context of hypoxemia, you can likely prioritize pathology in the alveolus. So for example, is the alveolus full of pus, fluid, collapse because of mucus plugging, external compression? And Reza mentioned this really interesting point where shortness of breath is subjective, but hypoxemia is not. And in this case, what was fascinating is that there was a disconnect because there actually was no dyspnea that had resolved, but there was hypoxemia. And in a patient with hypoxemia, important aspects of the presentation to consider are the preceding course before the hypoxemia and whether or not that contributed or influenced the current presentation, and then the time course. So to what extent was this a lingering hypoxemia? And when we got the ABG, we walked through that this is a picture of obesity hypoventilation syndrome. So we saw an elevated PCO2, but the pH was not low and the respiratory rate was normal. So we talked about how this was an indication of a chronic respiratory acidosis with appropriate metabolic compensation, indicating some form of hypoventilation. And when there's hypoventilation, we can think, is this impaired movement of air into the chest, or is this an obstructive problem? And the fact that there was no wheezing on physical exam indicated that this was more of an issue of impaired movement into the chest. So for example, an issue with diaphragmatic power from obesity hypoventilation syndrome. And then we also talked about in hypoxemia, in obesity hypoventilation syndrome, some of the causes include atelectasis leading to a VQ mismatch or chronic pulmonary hypertension. And then we also talked about this interesting pathophysiology where if the hypoxemia is unexplained by an intrapulmonary pathology, could they have a cardiac shunt? So an example of this would be hypoxia-induced vasoconstriction leading to acute pulmonary hypertension, which opens the PFO, leading to a right to left shunt. And you can use an echo with bubble to evaluate that further. But ultimately, this is a really beautiful case to discuss some of the more typical presentations we would see and to ultimately consider kind of the vulnerability in a host and their expected course. So awesome discussion, Robbie and Reza, and Alex. This was, again, just a really awesome case.
Oh, that was absolutely superb. Thank you. Those are like really, really tricky teaching points. And thank you for displaying them so clearly. And Alex, we're going to lean on you to present UTI, cellulitis, and COPD exacerbations because we gotta get those in too. Thanks,
Sounds like a
everyone.
plan.
See y'all later. Bye.